Okay, so my name's Ellie Jeram. I'm with Public Health Dorset in the intelligence team. Now, as an organisation, we've been looking at developing our data science offer across the health system, across the ICS. And so we were very fortunate that the three of us, all from Public Health, were able to attend HSMA 5, which was largely off the back of a recommendation from a HSMA 4 alumni. So a little bit of background as to what our project was about and why we chose it. At the time, we were sort of really developing as an organisation the integrated care partnership strategy for Dorset. And one of the key objectives was around the early intervention and prevention for sort of long-term conditions. And there was a lot of talk about excess mortality and the fact that we want to help our residents lead healthier, longer lives. So we started to sort of dig around on the excess mortality, the main issue being there are multiple definitions of excess mortality. So we came up with a project proposal of trying to understand these definitions, which ones were being used, why were they being used, what did they mean for us? So a little bit more perhaps of the analytical work from that point of view, but then to really try and develop a measurement that would be of benefit to Dorset and take into account our local variation against what's perhaps seen regionally and nationally. And then hopefully from there, we could identify periods of unexpected mortality, so be that excess mortality or reduced rates, and try and understand what were driving those changes that were being seen. So project process. So I've already sort of mentioned the fact that we were very fortunate that three of us from the same organisation were able to join HSMA 5. We were also joined on our project by Ruth Johnson, which was great as an external sounding board for what we were thinking, and coming from the NHS side of things, had less knowledge and understanding of excess mortality, perhaps, so we could really sort of get to grips with that and work out whether what we were saying made sense. We were also very fortunate that we had already had access to the primary care mortality data set, which gave us all the registered deaths within Dorset. And so a large part of data cleaning and data gathering was perhaps already done for us because we already had a little bit of understanding around that data set. The next thing was getting a virtual setup of all the software that we needed for HSMA training. As I suspect a lot of people on both our cohort and previous have had problems with getting IT to agree to download things like Python onto laptops. So they took a sort of virtual Azure machine to get around those security issues that they were having while developing a local solution, which we are still waiting for 15 months later. But it's coming. We've been told it is coming to take this forward. The other element of our project was the fact that because it was an exploratory project, really, we had quite a vague definition to start. So we had a lot of scope creep, and we backtracked a little bit and went sort of back and forth with what exactly it was we were trying to answer through conversations with the wider team within public health. So we started with that project proposal. We've done a lot of investigation. We've been able to apply lots of techniques that we've seen within the HSMA course, which has been both frustrating at times, but also illuminating on the data front. And sort of on a personal level, I've learnt a lot about my coding ability. I'm quite logical. I have a mathematics background, but my coding ability, I've hit that sort of limit. Which is great because I've got other members of the team who are able to do that coding. And it's really cemented my belief that any data science approach needs to be a multidisciplinary team. And almost the more people you can get working on this, as long as you've got that clear desire to get to a certain point, the better it is, because you're all going to bring different skills. And that's one of the great things about what the HSMA community has been able to bring to it as well, in the fact that they're always willing to help and they're only a Slack message away. So the output. So we've started to pull together what we have been applying to this data set. And like a lot of the projects here, we've started to develop a Streamlit output. The main aim of this is to make it free and publicly available. So we want others to be able to use their own data safely and securely. So having sort of that registry data for be it primary care mortality data set for their own area, or another sort of data set in a similar vein, they can upload their own data and explore it at their own leisure. And also hopefully allow our wider team to explore the data and ask their own questions. So with this Streamlit and with the Python coding and the HSMA techniques, we've been able to input the different data sources and do our standard data analytics. So this chart is showing all mortality across Dorset at an aggregate level, with the black line being one of the many current mortality baselines, which is a 5-year average based on months. So sort of January's average is the previous 5 Januaries. And we've also been able to add in elements to allow you to select the age range you're looking at or the time frame, so you can take out COVID years if you want to, and bits like that. But beyond those normal analytics that we perhaps look at every day, we've also sort of started to consider more detailed views, such as splitting it into a time series decomposition. So this looks at sort of the underlying trend, which is generally a 12-month rolling average. The seasonality, which is possibly a well-known fact that mortality does vary seasonally. We do get higher rates in the winter and the height of summer when it's hottest. And then the residual, which is the element that's not left, which isn't accounted for by either the trend or the seasonality. And in particular, in that bottom chart there, you can see 2 rather high points, which actually take into account some of the COVID-related periods. And finally, we're moving more towards forecasting, trying to create our own baseline, and we're looking at a univariate time series. So this only takes into account the seasonality and the trend elements. We have considered doing a multivariate model, which would perhaps take into account perhaps weather forecasts, average temperatures. We've been thrown a whole host of things, but I think because we're looking at creating a baseline, we want to be able to sort of keep it as simple as possible. So that seasonality and trend should hopefully give us a reasonable baseline to work from. And we're sort of seeing a fairly good performance with that. So our next steps are to continue to develop the app as it is at the moment with that forecasting, to build in the identification of those periods of unexpected mortality, and then to look at the populations within those timeframes to see how they vary with times that are matching that baseline element. We also want to work with outsider areas, such as some of the contacts that we've made or that have been made through Ruth, to see if we can sort of include some data other than Dorset and just to see how the two different areas perform. And we have had some interest from NHS England colleagues as well as OHID interest in how this approach compares to our other excess mortality definitions that we've got. I think that's it. It's kind of a whistle-stop thing. And other than that, I would just like to sort of say that, yes, highly recommend HSMA. It's been quite a steep learning curve, and I think it's always good to find your limitations. But that doesn't necessarily mean I'm going to stop trying to play with Python at every available opportunity.